invite Dr. Meyfroidt, who's the Associate Professor of Medicine at the University of Leuven and also an intensivist at the University Hospital there in Belgium. His interests include data mining and predictive modeling in neuro-ICU, acute kidney injury, and ketamine in brain-injured patients as well. He also represents Belgium at the European Society of Intensive Care Medicine as well. And he's going to be talking to us about something I think we often struggle with, which is neuroprognostication after TBI.
Thank you, Alex. Thanks for the introduction. First of all, I have no conflicts of interest because we're supposed to report them, but I have none. I come from Leuven, which is a town you might not all know. It's a small university town about 30 kilometers east from Brussels. This is our Grand Place and a very beautiful city hall. That's our hospital and actually the health sciences campuses. And then the other one are the Belgian beers. And at the end, on my last slide, it will be clear why I put up the beers here to sort of attract you all to come to Leuven. Also, we just got news. This is a bragging slide, I admit it. So so the Reuters ranking of the most innovative universities were out now, and apparently we're ranked number 7, and we're the first non-US university. So I'm pretty proud of that. But enough bragging. I wasn't invited to brag here. I was invited to talk about prognostication in severe TBI. So this will be the focus of my talk. Severe TBI in adults, mostly non-penetrating and in developed countries. Now, we've had the discussion yesterday about stopping therapy, and it's always a loaded discussion and sometimes becomes emotional, and I have the feeling that this has a lot to do with the uncertainty that is involved. And we all have biases. We all somehow prognosticate. We prognosticate for some conditions not really knowing which predictors we're using, or that not in a conscious way, and sometimes we do. And about TBI, I just want to sort of set the field and tell you what the prognosticators are and most importantly how we should use them. So this is what my talk will look like. In the first part, I will talk to you a bit about predictors and how you can combine them. Then I will talk to you about what our inherent problem is with neuroprognostication, and then I will try to answer the question I was asked to answer here. Do we really know when to stop and when to continue, and when can be interpreted as when in time and when as in whom should we stop and in whom should we continue. 1976, this is already for that time a very advanced model where they used Bayesian statistics to combine predictors in a cohort of TBI patients. Cohorts in 1976 looked a lot different from what we have now. Mortality was 60% and the median age was 32 years. So this is not the type of patient we see anymore, but it's kind of interesting how to introduce them. No one with experience in TBI patients would doubt the value of being able to do this, but many might doubt whether this is feasible. And in addition, these models should not automatically lead to a decision. It's entirely the business of the doctor to decide in whom to continue and in whom to stop. So let's talk about predictors. What are predictors? And this is a slide that I adapted from a paper from the Rotterdam group. These are actually, in theory, most of the factors that would determine the outcome of your patient. So you have patient factor, things that he had, the history, the age, socioeconomical status, things you can't change. Then there's what happened at admission, injury details, what type of injury, what is the severity of the injury, the intracranial and the extracranial injury. Are there any secondary insults already happened before he came to our ICU? What is the first CT? And then there's a clinical course of the patient. And how many of these do we use to predict outcome? Well, we could use some of them. I think genotype we could use in theory as well, but it's an enormous amount of data, so it's probably not something we would do right now. I think the biological response is also difficult to use, but all these other events or facts are things that we could in theory use to prognosticate. This is a survey by Alexis Turgeon amongst Canadian neurosurgeons and neurointensivists about which predictors they would think useful and which predictors they actually use. And I put a mark on the 70%, just to make it clear. It's clear that in some cases there are, so the dark gray is the ones that they think are useful, and the light gray are the ones that they use. And especially for MRI, you can see that actually most of them think it's useful, but only half of those who think it's useful actually use it. So what do they think is valuable? Vital signs, ICP and CPP is useful, GCS is useful, things that have to do with the brainstem are useful, and then CT and MRI are useful. Now, and I apologize if the following slides are a bit basic, but I find it, at least where I work, sometimes difficult to explain to clinicians how prognostic models are actually built. But it's very basic, so I apologize in advance for those who are familiar with that. So you have a data set, a database of a study, a couple of thousand patients, where you know the outcome. And you want to make a predictive model. And what do you do then? You do feature selection. You use some of these properties, like age, like the CT characteristic, whatever. You make a mathematical model, which is simply describing the relationship between these properties and the outcome. And this can be a logistic regression model, or this can be a machine learning model, or whatever. It's the same. You build this model. You internally validate this in your development cohort according to certain criteria that I will mention. Then you go back to your model. You might iterate this and make your model better until you have a final model. And then you can say, okay, this is my model, and it works like this. But, of course, this is built for your development set. So in order to know whether this model actually works, you take a new cohort that you haven't seen before, and you take the model there, and you try to predict the outcome. And then you feed back, and you do an external validation according to certain criteria. And the better models are validated across different settings. And in order to make them more generalizable, you would not recalibrate them, because then you could use them, for instance, for baseline baseline risk assessment if you want to include patients in a study. But if you want to use them for prognostication, you might want to adapt the model to the new data set, and so recalibrate the coefficients of the model to make it better. And I will explain you. And then what criteria are often used? Well, everybody probably knows the AUC, and everybody probably thinks that this is the most important parameter for a model, that AUC is high enough. And what does the AUC do? It actually tells you how well the model separates those with or without the condition, or in this case, the outcome. It uses a cut point, and you can say above this cut point you will die, below this cut point you will survive, and it's a balance of sensitivity and specificity. Whereas the calibration is actually the agreement in your data set between the observed and the predicted risk in your population. So it has to do with disease prevalence, and you can use several methods. I personally like calibration curve because I'm a graphical person, and that's then how it looks like. An AUC curve, I think most of you know them. They always put them in this paper. It's actually the most redundant curve that there is, because you don't need to see the curve, you just need the number, but still everybody puts them in their papers, including we, because this is one of our papers where we predict pediatric outcome based on NIRS. And then below we have a model that predicts, for instance, ICP rises based on the previous ICP data, and what you then can clearly see is that the two curves on the left, the model is well calibrated, but in the curve on the right is less calibrated. And why is that? Because the model was developed in adults, and the population on the right are children. What is important in prognostic modeling is everybody thinks the AUC should be high enough, but actually AUC is mainly important for diagnostics. For prognostication, you want to know, is this model working in my population? So in those cases, actually, calibration is more important than an AUC. Of course, both are important, but it happens that AUC is just an easy way to compare, and calibration is not as easy to quantify, but you always have to look for that. And nowadays, we even want additional criteria, because we want to know whether, and I will not present you any model where these are used, but this is actually a quantification on what does the model add in reclassifying my patient, in which risk zone does it add information. And for instance, the curve below are decision curves, which we currently use, where you actually compare what your model does, which is the line above, against the horizontal line, which is simply where you would treat nobody or where you would stop in no patients, and the dashed diagonal line is where you would treat all patients, and then the benefit would be only in those patients with the condition or the outcome. And then you can see in which range that your model would do better. So I think they should do this, but they don't do right away for their models. Okay, do we have clinical models to predict TBI outcome? Well, I think there's 3 good models to me. There's the model by Hückelhoven, the impact model, and the crash model. I will discuss them briefly. The Hückelhoven model was based on 2,000 patients. They found 7 predictive characteristics. It was externally validated in European and American data sets, had an excellent AUC, but was not well calibrated. And I just explained you why it's so important to have a well-calibrated model. Let's go to the impact model. The impact model developed by the Rotterdam group based on a large data set, and it sort of builds up. You have a core model that uses age, motor score, and pupils. Then you add CT data, and you can add CT and lab data. And so the model was developed in a huge data set of 8,500 patients, and it's really impressive to get so many TBI patients, because nowadays most centers do not admit large sets, so you need a lot of centers to collaborate. For 5 RCTs, 3 observational trials, robustly internally validated, robustly externally validated in the crash dataset that I will mention right away, with good AROCs as well as in other datasets. So this is a model that we are pretty certain that it does what it's supposed to do also in other settings. And so that's the result that you would get then. You would fill something in, and then you would get a predicted probability. Now let's go to the third model, the crash model. The crash model, and you can actually, you have to fill in the country as well, so I just wanted to see whether Belgium and Australia compare, but we do the same. So when you have the same risk in Belgium or Australia, at least according to the crash model, you have the same outcome. It predicts 14-day mortality, 6-month unfavorable outcome, and it uses, in addition, major extracranial injury, which was not there in the impact model. Also robustly internally and externally validated. And what is very funny or peculiar about these 2 models is actually the same group of researchers that built it, so you might wonder why they didn't join the databases, make a 15,000 patient database, and make the model even stronger. But from these models we can conclude robustly that, and this had been known already before the models were made, but this is the confirmation of that in age, the GCS motor score, and the pupils at admission, actually the largest amount of prognostic information from our patient is present, which means that actually every model later should probably start from there. Another external data, and just to show you what the effect of recalibration is, this is a study by David, I forgot to put the reference on, but it's a study by David Harrison and the UK group. It's a range study, 67 ICUs, 3,000 patients. He compared the 3 models, and he came to the conclusion that the impact lab model was actually the best, but it was not well calibrated because it over-predicted in the low-risk patient, as you can see on this graph, but then they recalibrated the model to make it better. It didn't do much on the AROC, but then at least they had a model that was usable in the ICNARC centers. Clinical predictors, imaging predictors. Well, we know already from the models that there are clinical predictors that there's information in our CTs, in our initial CT, the Marshall classification, whether there's subarachnoid hemorrhage, whether there's an epidural hematoma. Petechial hemorrhages in the crash model was predictive, but a more recent paper has actually refuted that and said, well, in this series of a couple of hundred patients, it was not associated with poor outcome. So we should not always think that this initial diffuse axonal injury on the CT is bad. And then paradoxically, if you look at it on an MRI, it is bad. So if you, the MR predictors, and I was lucky that this meta-analysis was just published last year because it was a lot of work to synthesize MRI data. But if you look at MRI data, in general, what is associated with bad outcome? Lower lesions, so the more caudal your lesions are, it's associated with worse outcome. You can't really quantify the prognostic role of MRI because of the data are not so, it's usually small series and the studies have a high risk of bias. But low lesions, brainstem lesions, and in these series also diffuse axonal injury are associated with unfavorable outcome at 6 months. Now let's move to biomarkers, because wouldn't that be fantastic? We do a lab test and then we know which patient will do good and which patient will do bad. Another meta-analysis also from the same group actually. Higher NSE associates with mortality and unfavorable outcome, but we have no thresholds, we have no cutoffs, and it's all small studies with high risk of bias, as you can see, in total 346 patients, but on average there was 17.25 microgram per liter higher NSE in the unfavorable group versus the favorable group. And actually you can tell the same story about all the other biomarkers, that is that it's all done in small patient groups, it's all done with high risk of bias. There is an association with worse outcome if the value is higher, but there's no thresholds. So to me, for the moment, we can't really use biomarkers. Electrophysiology, to my surprise, there's very few data on conventional SEP and EEGs to use them for prognostication, so maybe that's an area for research. There is some data on spreading cortical depolarization, where you would have to put an invasive cortical probe, and it does independently correct it for impact score, but it's usually viewed rather as a target for therapy rather than a predictor, but it does predict outcome. Now, if we talk about secondary injury, how can you quantify secondary injury? And this first paper by Anne Vick on the left side, where she actually quantified the association between the dose of ICP above 20 millimeters of mercury, which is an area under the curve, which was more predictive for outcome than fixed, than just using the threshold. And you can clearly see that the higher your dose, the higher the likelihood of poor outcome. On the right side is a paper that we published where we used, well, you could see it as a sort of a sliding scale. So we didn't look at patients in this curve, but we looked at ICP events, and we looked at, on average, which type of ICP event would be associated with higher or lower GOS, and we assigned a color to that. And so red is actually associated with worse outcomes, with mortality or worse GOS, whereas the blue would be associated with better outcomes. And then this curve came out, which actually indicate that the longer the ICP is above a higher threshold, but you can do that for any threshold above 15 millimeters of mercury, the worse the outcome is. And in our group, corrected for impact, this was an independent risk factor for mortality and for worse outcome. Now, can you, because there's a lot of work about big data now, so can you actually use big data or machine learning techniques? Also something we tried to use the monitoring data, so the ICP data of the first 24 hours in addition to impact, and see whether it actually predicted better. And so we made a machine learning model because we decomposed the signal into so many attributes that you can no longer analyze them with traditional statistic techniques. And we looked at the probability of unfavorable outcome. And we did this in the BrainIT database. And what could we see? That indeed, just using the prognostic calculator was actually not so good anymore. It had a very low AROC, which is probably unacceptable now. And then if you look at the calibration slope, was also not so good. If we would recalibrate it, we were able to improve the calibration, but not the AROC. And then if we added the monitoring data, the model became a lot better. Okay, but enough about prognosticators. Let's now talk about predictions. How do we predict? How do we use these? Because prediction is actually then using these prognosticators to decide on your patients. And the Canadian group did a very interesting survey, which consists of several parts, and you will see other parts of that survey later in my presentation. But first of all, they asked the Canadian intensivists, what do you think is unfavorable outcome? So how would they dichotomize? And they would say GOS 1 to 3, according to 71% of the respondents, was unfavorable outcome. When would you want to know? In Canada, they would like to know within the first week. They think it should be within a week. Within a month was considered not so good, according to the respondents. Now, if you predict and you get a model, and you give it to the clinician, does it change management? Well, apparently it does. And so this is an older paper from 1993. So if you gave the predictions, and the patients in whom the outcome was predicted as good, they got higher care, whereas the patients where the outcome was predicted as poor, the care was reduced. And this could be a self-fulfilling prophecy, of course, because you could fool yourself and make sure that you're always right. And so Susanna Mulschlegel and her group did a prospective observational trial in a group with 36% mortality, and of those who died, in 68%, this was after withdrawal of life support. And what could they see? That there's a lot of things that predict worse outcome, but in the patients where they decided to stop therapy, it took over from all the other predictors. So just deciding to stop, you're becoming very efficient in making your prediction work. And then they did a survey. They gave them a couple of clinical vignettes with a patient 3 times different scenario, but the outcome was also always a GOS 3, and they asked specialists, can you predict the outcome? And actually they were very good at predicting that. And even knowing that the outcome was bad, they still recommended initial aggressive care. The Canadians did the same. So the survey that I talked to you before is connected to this study as well, where they, in 6 centers, collected data on 120 TBIs, so that's 720 TBIs, comparable mortality than Susanna Mulschlegel's group, and also comparable ratio of withdrawal of life support, and no patient survived the withdrawal of life support. But what is kind of worrying in this survey is that the rate of withdrawal of life support was highly variable among centers. So in some centers it was almost 90%, in some centers it was less than 50%. And this center effect remained after adjusting for baseline risk. So it was just, regardless of the condition of the patient, in some centers they would stop therapy more and earlier than in the other centers. And so it's actually the center variation that accounted for the mortality rather than the baseline risk, which is maybe a bit worrying. And so what are predictors of withdrawal of life support? Well, clinically, there was CT characteristics. So whether there was herniation, it increased the risk of withdrawal of life support. When there was an epidural hematoma, it reduced the risk. And then the fact that you engage in therapy, that reduced the risk of withdrawal of life support. So if you did a craniectomy, you tended to treat them longer, and if you did other surgery as well. So apparently when a surgeon is looking over your shoulder, you tend not to stop so easily. They also gave him a baseline scenario of a 25-year-old man with a GCS of 6 following blunt TBI, and they asked him, can you predict his neurological prognosis at a year? And you can see the graph on the left. Roughly, it's like a third, a third, a third. One would say good, the other would say bad, and the other would say, I don't know. But then if you say, are you comfortable with withdrawal of life support, even with this high level of uncertainty, there's still 8% who would be very comfortable in stopping therapy in this patient, which is maybe a bit weird. But luckily, 82% was not very comfortable in doing that. And then they added predictors to the scenario, like what would make a doctor change his mind. And the predictors are listed here. So the percentage on the y-axis is the number of doctors that would change their mind when the parameter is added. And for instance, dementia, then 80% would say, okay, if the patient had dementia, I will stop therapy, bilateral dilated pupils, best GCS of 4, and so on. Then they would be inclined to stop therapy earlier. Now finally, I was asked to ask a question. Do we know when to stop and when to continue? And some annoying data maybe. This is a functional MRI by Virginia Newcomb from the Cambridge group. And so the patient on the top they take functional MRIs at 6 weeks and at a year. And what you see, I don't know if you're used to looking at that, but you clearly see in the temporal zone that there's rewiring, so that you see recovery of white matter integrity, and this was associated with better outcomes. So this patient actually improved and did better, whereas the patient number B actually even further lost white matter And so this patient actually did worse. So it turns out that TBI is not something that happens and then in 2 weeks or 3 weeks or a month in the ICU is treated, and then no, it turns out that even after a year we see things happen. We see patients. And so this is, of course, knowing that we might be biased, that we're certainly biased in stopping therapy, and that stopping therapy is the most important predictor for outcome. This is maybe a bit concerning for us. And we actually do not know what would happen if we would continue. And those settings where they do this, we don't get any news from that, how it's going. And I'm putting Schumacher there because we don't know how he's actually doing. We assume that it's not good because otherwise we would probably know, but we don't know. Just like in Israel, for instance, where there's a culture of not stopping and keeping people in the ICU for a long time, but we don't have any series from there how these patients actually do in the long run. Because this could learn us, those who do stop early, maybe this could learn us a lot. Now we can only assume that it's not so good because the data are not published. And I'm going to end with maybe a provocative slide, which is a sort of a proposed timeline of maybe how we do it in our center, more or less. And I think the prognosticators in the first 24 hours are mainly concerned with the severity of the primary injury. How bad? Is this actually a salvageable brain injury or not? Is this a disastrous CT with herniation, with diffuse damage, or is this an epidural that we can just drain? Do we see clinical sign of a brainstem that is damaged or not? And then we start, because if we assume that it's salvageable, we will start. And for 1 or 2 weeks, we're actually concerned about secondary injury. And so we would repeat the CTs, and if of course this is catastrophic, we can stop there, or we can see clinical neuro worsening, or we can use our neuromonitoring data, and we have a patient with an uncontrollable ICP, and it's a disaster. But else, these 2 weeks are probably our intensive therapy. And then we stop the sedatives, and we wake them up, and we see how they evolve. And we might do an EEG to see whether, when they're not waking up, whether it's not seizures. This is the phase where we probably would do an MRI, because it's more feasible to take them to the MRI. And what we want to estimate in that period is actually, will this patient recover? Is this somebody that we send to rehab or not? Maybe this is where we should do fMRIs. We don't do them right now, but this is maybe the phase where we have to do that. And what we still can do in this phase, but this is in my country where legally euthanasia is acceptable, and where we do refer them to palliative care later. But we can still decide, even after 6 weeks, 2 months, to send patients to palliative care instead of to rehabilitation. And I want to end with these final remarks that we're never certain. So we have to know and realize that, but the fact that it's uncertain is actually better than if we would be as arrogant to assume that we are certain. And it's good to understand why we predict this. What do we use? What are the arguments for this patient to stop? In my opinion, the evolution over time is our most important prognosticator. And when you're uncertain, you can postpone. And I no longer agree with what Teasdale wrote about it's entirely the business of doctors, because that's no longer true. It's something that you have to do with the family. And what I always say, rather than advanced care directive, is probably a caring doctor and a loving family who can somehow come to a consensus on a patient, on assuming what his wishes would have been, and on it's our part to give him the expertise of what is to be expected. And that's why I put up the beers. Next year we organize the ICP meeting in Leuven in September, and I hope to see many Australians there. And I'm sure you'll get a taste of the beer there if you come. Thank you.
If there's anyone who'd like to come to the mic and ask a question, in the meantime I'd like to ask one, because you mentioned euthanasia, and as someone who works in one of the few countries in the world where it's legal, also working as a neurointensivist, for the Victorians in the audience who from the middle of next year will also be working in a state where euthanasia is legal, I'm interested in the intersect between neuroprognostication and euthanasia, and whether they interact at all.
Yeah. Well, what is quite, it's a very good question. And what is quite interesting is that I think we can allow ourselves to continue longer because we know that we have the possibility. So either the patient regains consciousness and decides that his life is unacceptable, then he could apply for euthanasia because he thinks that he was so damaged. If he doesn't recover consciousness, we cannot do euthanasia legally because it is the patient was to request this. But because we can refer him to palliative care even at a later stage, I think this can allow us to be more aggressive in the beginning, and maybe paradoxically we would stop less inpatient because we're not afraid of these long catastrophic cases where for instance, somebody would put in a tracheostomy or hesitating about putting in a tracheostomy because you know, okay, nobody's ever going to pull it out, and then the patient's going to end up in this long care facility with a tracheostomy for years and months, and nobody will stop nutrition or other things. This is something we can still do, and so we keep them hospitalized, let's say, if we're uncertain, 6 weeks, 2 months, and we might never decide to send them to rehab.
There's a certain perverse nature in my mind that you have to get better enough to want euthanasia.
Yeah.
You can't do that if you're too incapacitated to be able to request it. So then we come to another law, of course, that is that no doctor in Belgium can be forced to do something that he doesn't think is beneficial for the patient. So which means that if we don't think it's beneficial to give him nutrition and fluids, we can stop that and move to palliative care. Yeah. Any questions from the floor?
So if not, thank you very much, Geert, and I think maybe people will follow you up afterwards.